Assalamu alaikum. I think it's the time we should start the session. Thank you very much for attending this 40th webinar and on competency-based medical education and entrustable professional activities. Some of my friends from Iraq might find a bit of repetition because recently I had presented on these topics, the shorter versions in different cities of Iraq. Okay, let's move on to this presentation. Right, now, since the beginning of this century, the 21st century, competency-based medical education has become a new standard. And I'll share the list with you, the medical schools which are following it towards the end of this presentation. But this is something which is catching on very, very fast. And in this process, the detailed framework of competencies, means the competencies have been identified and detailed frameworks have been prepared so that the students who are going to graduate must demonstrate these competencies before they are declared successful in their graduation. However, the competencies which are qualities related to the knowledge, the skills, and the attitude do not directly translate into everyday activities of physicians. These are the points which we would explain quite in detail along the presentations. So the point here is that the ability to perform lumbar puncture, for example, does not necessarily mean that the graduate can manage a patient with a meningitis. So that is an example that there is one competency which is, let's say, a graduate is able to perform a lumbar puncture, but we cannot assume that that graduate would be able to manage a patient with meningitis. So that is the way, the limitation which I was saying, that the possessing a competency does not directly translate into everyday activity of physicians. To overcome this challenge, the entrustable professional activities were introduced around 2005. Now look at this Miller's pyramid of clinical competence and EPAs. I think all of us are familiar with Miller's pyramid, and it has 4 stages: knows how, shows how, and does. But now this EPA is on top of that. If you see, the shows how means the assessment focuses performance in controlled settings. For example, in clinical skill labs in the form of OSCE, practical or simulation, standardized patients. The does level is performance integrated into the workplace. And the methods of assessment include 360-degree assessment, case-based discussion, clinical competencies, are directly observed practical procedures, etc. But the EPA comes on the top, and this shows the readiness to cope with challenges in practice. And although the assessment methods are same as at the does level, but here an addition is entrustment. Let's take this example. There's a student who has graduated, so he has fulfilled the does level. But then the question is, would you like to be treated by this graduate? If you say yes, that is trust. But if you feel no, although this student has graduated, but I don't think I would like to be treated by this graduate, this means that although student has graduated, but he or she has not won your trust. That is the difference between competency and EPA. That EPA means that this means that institution has to issue a certificate that following competencies, we can issue that this student can be trusted to perform without any supervision. So that is a clear difference between a competency and entrustment, and it would be elaborated further. So with that background, the learning outcomes of this session, the participants would be able to explain the concept of competencies and competency-based medical education, clarify the perceptions about Entrustable Professional Activities as EPA, discuss the link between competencies and EPAs, explain the concept and operational aspects of programmatic assessment, because the programmatic assessment would be the recommended way of assessment of students if we want to implement competency-based medical education. So we will cover that aspect as well. Propose the implementation plans of competency-based medical education in institutions of higher learning, and manage the challenges in the implementation of competency-based medical education. So these are 6 learning outcomes which we will, inshallah, try to achieve during this session. The definition of competency-based medical education, I will present few definitions one after the other, and we will see how these definitions clear our concept about competency-based medical education. So it is a model for designing and implementing education that focuses on the achievement of desired performance characteristics. So our focus is on achievement of desired performance. So it is different than, let's say, learning objectives, when we used to say that student will be should be able to. When we say should be able to, is just our desire. Whether student is able to do or not is a different thing. But competency-based medical education ensures that the graduate will be able to perform for example, a procedure. In a way, we take the responsibility, we become accountable, because once we issue a certificate, this means that we have taken the responsibility for the student to be able to perform that particular action. Second definition, the competency-based medical education model is set to improve students' competence by predefining educational outcomes, also known as EPAs, that support learning and teaching activities. So here emphasis is on predefining, means that the competencies need to be predefined, and then the whole curriculum must be developed on that. So the plan would be that we identify what competencies our graduate must achieve before they graduate, and then the whole curriculum would be based on that list of competencies. The educational, the teaching methods, the assessment methods, everything would be directed towards that. The habitual and judicious use of communication. So here is another definition of competency-based medical education. The habitual means that the student becomes so comfortable with that competency that becomes a second nature, and student does not need to really think much or do much effort. For example, if we say that student is able to or will be able to set an IV line. So that should become just a routine kind of activity for the students, and they can perform this procedure very easily without much trouble. Judicious means that the procedures are whatever actions they are performed, they are really indicated. There are strong reasons to perform that action. So they cannot be performing certain procedures if they are not needed. And this is, it covers the communication, the knowledge, technical skills, clinical reasoning, emotions, values, and reflections, and that is in daily practice. And purpose is to help the individual and community and not helping themselves. The medical competency is defined as a learnable, durable, and measurable ability to execute a specific integrative task that is part of full range of tasks. So it is something which is learnable and which is measurable, and it is specific, and it is integrated in the daily practice. So those are some definitions of competency-based medical education. And now question is how to identify these competencies. An important point here is that competencies are defined by external bodies. That is what is requirement, for example, by Ministry of Health, what are the requirements of the community, what are the requirements of the patients, or what are the requirements of peers and other colleagues. So those are the things which would make the list of competencies which a student, graduating student must exhibit. This means that the competencies are identified not internally, but externally and from the different bodies. Second point here is that using absolute standards that is independent of other learners' performance. We know that there are two ways of assessment. One is criterion-based, where student is assessed against a standard criteria that is criterion-based, and the other is norm reference, where student's performance is assessed in comparison to his or her other colleagues. So that is relative. But here in competency-based medical education, we are assessing the students against certain criteria, which is independent of the performance of other students. Right, now this is the age of AI. So I thought I'll look at the definition of CBME in Copilot. And it says that competency-based medical education is an approach to training healthcare professionals that emphasize on achievement of specific competencies. We have mentioned this previously as well, that the focus of competency-based medical education is on achieving some specific competencies, and this means to make sure that a graduate has really achieved those competencies, which may be a skill, knowledge, or attitude, and required to perform effectively in clinical practice. Now, this is another very important point about competency-based medical education. Instead of focusing primarily on the duration of training or theoretically coursework, CBME assesses learners based on the demonstration of required competencies. This means that competency-based medical education, the original concept, is not based on the duration of a course, let's say 5-year course or 6-year course, but it is based on the achievement are obtaining the required competencies and a demonstration of those competencies. So this is an important point, and we would elaborate quite in detail. The first is that competency-based education is not related to the duration of training, but it is related to the achievement of required competencies. CBME is an approach to training healthcare professionals that focuses on the achievement. So we have emphasized this point in the previous slide as well. And progress is based on learners' demonstrated mastery of knowledge, right? So this means that the progress of student from one stage to another is not based on the time spent in the program, but based on the ability to demonstrate the desired and identified competencies. And if a student can demonstrate that, so they can be promoted to next stage of training or graduation. So the definition based on the Chat GPT and the Copilot, that is the AI definitions. So competency-based medical education emphasizes on clear outcomes, the defined competencies that graduate must achieve. Number two, learner-centered progression. Advancement occurs when competency is demonstrated, not automatically with time. So student has to demonstrate the required competencies before they are declared successful. Assessment for learning. So frequent formative assessments to provide feedback and guide improvement. Accountability and transparency. The training aligns with patient and social needs, ensuring graduates are truly prepared for practice. And that was, I was emphasizing in the beginning, that when we are following the competency-based medical education, the institution is becoming accountable, is becoming responsible for the abilities for which the student has been declared and trusted. And flexibility, it allows learners to progress at different paces based on their achievement. And this is again a big issue when we want to implement competency-based medical education. Then it's difficult to follow this rule, because our most of the institutions are time restricted, and how to implement competency-based medical education in these time restricted courses, I will present some solutions to that. So CBME shifts medical education from a time-based curriculum-centered model to an outcome-based learner-centered model focused on real-world professional performance. So this is a big difference, actually a huge difference between our present system and the competency-based medical education. So what is a competency? It is specific. It is integrative, means that it's related to each other, durable, focused on performance, learnable, and competencies are mutually dependent. So these are some of the characteristics of when we say competency-based medical education. So we need to define what is a competency, and these are few important features of any competency. Now, once we go through this, we recall what was the outcome-based education and know what are the competency-based medical education. So here is a little comparison. Competencies are specific, are learnable, are integrative, are mutually dependent, focused on performance, durable. So if we want to make an acronym, it can be like SLIM, FD. Whereas the outcomes are also specific, measurable, achievable, relevant, and time-based. And the acronym is SMART for this. Now, there was a question by one of our colleagues, I think Arshad, Jamshed Arshad, he wrote me a question about it, that why I am saying outcomes are time-based, but actually outcomes were not time-based, or they are not time-based. Yeah, that is true. The competencies and outcomes are actually very, very closely related, and there are some very fine differences. The outcome-based education in the beginning was defined exactly like competency-based medical education, that it is not time-based. It depends upon the achievement of outcomes. And as soon as the student achieves those outcomes, they can be graduated. But now with the time, what we have seen is that the outcomes have become specific. For example, we have outcomes for a module. We have outcomes for let's say rotation. We use different, let's say, even for there are outcomes for a teaching session, like I have specified the outcomes for this session. So in this way, in practically, the outcomes have become time-based. When I said that we have these 6 learning outcomes for this session, means we want to achieve these 6 learning outcomes during this session. So point here is that although in the beginning the definition was not related to the time, but over these years, the practical applications has actually made outcomes as time related. So that is the now difference between a competency and an outcome. So as I said in the beginning, that the institutions who are applying or following this competency-based medical education, they have identified the competencies are the roles. And here is one example where Canadian medical education directives for specialists, they have identified 7 competencies are roles of a physician, and which include, number 1, medical expert, which means that application of knowledge and skills in real life situations. Number 2, communicator. 3, collaborator or teamwork with peers and other healthcare providers. Leader, scholar, health advocate, and professional. So these are the 7 competencies or roles identified by the CanMed. This means that this is what is expected of a newly graduate student who is entering residency to have these kind of competencies. Here is the sort of different presentation where medical expert is in the middle, and all other competencies are around that, because these competencies are actually the contributing to the main role of medical expert. If you look at this slide, so it seems that only medical expert is related to the medicine, and rest all the competencies are different. But actually, if we take away the medical expert, the other competencies becomes meaningless as long as the medical profession is concerned. So medical expert is the most important competencies, and there are other competencies which would contribute to the better medical practice. Similarly, the Accreditation Council of Graduate Medical Education in US, they have identified 6 competencies, and they are patient care, medical knowledge, interprofessional and communication skills, practice-based learning and improvement, system-based practice, and professionalism. Now, each of these competencies would have a number of characteristics in that. For example, patient care here has 6 characteristics, means there is an academic strength, there is a compassion and empathy, there is communication, there is work ethics, motivation, there is a teamwork, and there is diversity. Similarly, medical knowledge would have academic strength and the work ethics and leadership. So this means that these competencies, each competencies would have detailed characteristics, so which would make it a complete program to be implemented. What do we want to achieve by implementing competency-based medical education? The fundamental goal is to empower students with competencies in communication, collaboration, professionalism, and health advocacy, amongst others, and to cultivate unique intellectual, emotional, and physical abilities so that at the end of the day, there is improvement in the patient care. So that is the main goal. And by applying these different methods of teaching and assessment under competency-based medical education, we want to achieve that goal. And actually, that has always been a goal of medical profession. So just to summarize and clarify these points about competency-based medical education, there are 2 defining features of competency-based medical education. Number 1, its focus on outcomes formulated as specific competencies. Number 2, its independence of length of time in training. So these are 2 really, really defining features of competency-based medical education. So this means that competence-dependent certification instead of time-dependent certification, and which is the similar concept as we see in Bloom's taxonomy of learning. Right. So that is the first component, that is to be able to explain or understand the concept of competency-based medical education. And here is a short quiz. You can write your answer in the chat, or you can write on the paper in front of you and see whether we have really understood the concept. CBME focuses on predefined competencies. One statement. B, assessment as learning. C, flexibility in the duration of the course. D, learning styles. So in this quiz, the B would be a wrong statement, because CBME is assessment for learning, because we assess the students along the way and we give them feedback and they improve on their learning. So CBME is not as learning, or is not more of summative or for learning. And then the D is also a wrong statement, because CBME does not actually consider or does not pay much attention to the learning styles. So before we move on to the next session, which is Entrustable Professional Activities, any of the participants, if you have any question or query, we can discuss that before moving on to the next session, next section. Yes. Anybody has any comment or question on competency-based medical education? Yes, sir. Please unmute yourself. Yes.
Yes, sir. Thank you very much, Professor Alamsher Malik. My question is regarding time duration and demonstration. Because
Right.
CMBE emphasizes much more on demonstration of competencies than on time duration.
That's
So
right.
do you suggest that the undergraduates and graduates and then specialized qualifications, should they depend only on the demonstration? So that means MBBS curriculum first varies from student to students, and similarly the post-graduations like doctoral programs or fellowships or the others, they depend on competency, and the duration will be different from where for different students.
Right. So that's an important aspect, and I have a full section on that to discuss the competency-based medical education in time-restricted situations. At the same time, we should keep in mind that when we say competency, it is not just a procedure. It also includes other attributes as well. And if you allow me to move on, and I think I have quite a number of slides on that area, and inshallah we will be able to discuss that in detail, that how we have these competencies and how do we assess those competencies and how to implement within our restriction. Let's say we have a 5-year MBBS program or 6-year MBBS program. So we are time dependent. So how we are going to implement this competency-based education within our restriction of time-based. Inshallah, we will cover that in detail.
Thank you very much, sir. Thank you.
Any other comment? Any other question? Right. So let's move on to the second component. Yes, sir. Please unmute yourself. Yeah.
Assalamu alaikum.
Wa alaikum assalam, sir.
Alhamdulillah, you reached Malaysia safe. Alhamdulillah. We are more than
yes.
I am Dr. Muhammad Saeed from Kufa.
All right. This is Professor Muhammad Saeed. He was very kind to host me in Kufa in last week. And we, as I said, we had some shorter presentation on this topic as well. Yes, sir. Professor
Thank
Muhammad.
You very much. So, thank you very much. For competencies like history taking, you know that this is context specific. So a student should be competent in history taking from a child, from woman, from patient with psychiatric illness, patient who is angry. So how we can know that he is now competent in history taking in those different type of patient, different type of context, different type of. Thank you very much.
Thank you very much, sir, for that question. Now we have to identify these competencies. For example, you are talking about communication. So let's say, we say that student would be able to communicate effectively with an angry patient or with a child or with a parent. So under the communication, we would have these competencies, and then as a continuous assessment, because the competency-based medical education, as I mentioned, it emphasizes on the programmatic assessment, which is mainly the continuous assessment. So these things would be assessed in the workplace-based assessment program, whether, for example, the student was able to communicate well in a pediatric ward with the children, or was there any occasion that there was an angry patient and this student was able to communicate. Otherwise, we can have the OSCE stations as well. And actually, we used to have, during the training session, we used to have these sessions, and we would have this simulated patient, and one of the simulated patient would behave like a very angry, agitated person, and then the student would communicate with them. So you are absolutely right, because under each domain, and we are talking about the domain of communication, we have to list down different situations which are important for communication. For example, listening is an important component of communication. So we need to assess these, our students, our graduates, on these areas, maybe during workplace-based time. I hope that answers your question.
Yes,
Yeah,
thank you very much. Thank you.
Yeah, next is Dr. Vidya. Please unmute yourself. Yes.
Yes, sir. Thank you. So my question is, and many people have asked also, that outcomes and the competency, there is a slight difference. Where we have measurable outcome, we do not have a measurable competency then, or is it like overlapping some of the SMART into this CBME competency?
Yes, actually, there is a lot of overlap, and there are many things common between the two. The acronym of SMART and the SLIM FD. And one point I was discussing, which one of our participants had written me to answer that question, that to begin with, when the first outcome-based education, or OBE, was introduced, outcomes were also stated as independent of time, are flexible, but somehow over the time, as we see in our sessions, we have outcomes for our modules, or our rotations, or our sessions. So that has become sort of acceptable as time-based. But you are absolutely right. There are no major differences. In fact, there are some fine differences between outcome-based medical education and the competency-based medical education.
Thank you, sir.
Right. Any other comment before we move on? Right. Now, let's move on to the entrustable professional activities. And please remember the example I gave you in the beginning, that a student we have assessed is able to set an IV line, and we say, okay, student has achieved that competency. But the question would be, would you like, in certain situation, that this graduate would set an IV line on you, or your or any the loved one, your loved one? And if you say yes, that means that you have trust on that student. But if you are hesitant, means that actually, although student has competency, but student has not won your trust. And with that background, let's look at EPAs. Okay, now this is definition for a graduating students, means the definition for a graduate who is going to be a house officer. And it says a unit of professional practice. And in below I have written for example, the management of a patient with myocardial infarction would be a unit of professional practice. Setting an intravenous line would be unit of professional practice. Managing a patient with dehydration would be a unit of professional practice. That is the definition of unit of professional practice. So with that concept, EPA is a unit of professional practice that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute this activity unsupervised. So there are few words here. One, professional, the unit of professional practice, which I have explained. Then second is the trust, which we already have spoken. And then it has to be the necessary competence. And the most important is unsupervised. This means that there are these units of professional practice which we have trained our graduates so well that when they go for house job or residency, they would be able to perform these units of professional practice unsupervised. This means that we should have a discrete list and a complete list of units of professional practice for which we can show that we trust, we declare that we have trust on this graduate, that he or she would be able to perform in the real life situation during their residency training. So that is definition of entrustable professional practice, a unit of professional practice which can be trusted, that a graduate is able to perform unsupervised and has achieved the necessary competency in that. So entrustable is act that requires trust. Professional, we are talking about the medical practice, and activities means the tasks that must be done, means that we must identify what are the activities graduating student must do, and those would be our competencies, and based on that we would develop our whole training program. Like we mentioned, the competencies identified. Similarly, the American Medical College has identified 13 core EPAs that all entering resident should be trusted to perform with no supervision upon entering residency. This means that the Association of American Medical Colleges, they are declaring that there are these 13 EPAs which any resident and any graduate who is going to for residency can be trusted to perform without supervision. So this means that is the minimum requirement for any graduate to enter a residency program. And here are those 13 EPAs. And if you see, they are very, very basic requirements of any house officer. EPA 1, gather a history and perform a physical examination. EPA 2, prioritize a detailed differential diagnosis following a clinical encounter. EPA 3, recommend and interpret common diagnostic and screening tests. So history taking, physical examination, differential diagnosis, asking for investigations, interpreting the investigations, then enter and discuss orders and prescriptions, document a clinical encounter in the patient record. So similarly, up to the number 13, identify system failures and contribute to a culture of safety and improvement, that is the patient safety. So if we look at these 13 EPAs closely, they are actually very, very important and basic requirements for any graduate who want to start the residencies. So what the requirement now is that the institution must issue a certificate of trust that this graduate is able or is trusted to perform these 13 EPAs, so he or she should be allowed to start the house job. And while going through this, I realized that maybe there should be another EPA, which is number 14, that the graduate understands his, her, or her limitations and knows when to call for help. I think this is very important, that each one of us in medical profession must know our limitations and should not hesitate to call for help when we are in difficult situation. So the house officer should have this courage, this understanding, as well as this the assurance from the seniors that he or she can call for help whenever is needed, and that would be provided. So basically, now we looking at this EPS would tell us the scope and the requirements and what we are looking at. And if you see, we are looking at very, very basic things. And we want that any graduate who is entering house job must possess these abilities or competencies. Now, as we know, that trust has different levels. We have a friend and we have a best friend. Similarly, the EPAs have a different level of trust, and this is that so far we have been talking a graduate, but obviously there are EPAs at lower level as well. If we talk about EPA level 1, means that our criteria for admitting a medical school for a candidate should be enough that learner is allowed to be present and observe, not to enact an EPA. So we, let's say at year 1, we are not requiring any student to do an action, but they should be qualified enough to observe. Similarly, then is the level 2, the learner is allowed to execute an EPA, but under supervision, direct supervision, proactive supervision, and the supervisor is present in the room. The level 3 is the learner is allowed to carry out the EPA with indirect reactive supervision, means that student can perform that procedure, but the help is available on request. Level 4 is the one which is really a house officer level. The learner is allowed to work unsupervised, whereas level 5 is the learner is allowed to provide supervision to more junior learners. Means that level 4 may be for a house officer, and level 5 would be for practitioner or medical graduates who are, let's say, at the level of registrar, senior registrar, and lecturers and all that. So that is basically these levels of EPS are meant to help us to plan a training and of the students, that this is the level what is required at this stage, and then student can move on to the next level only after completing the lower level. Right. So now we have discussed what are competencies. We have discussed what are EPAs. Now question is that what is the link? What is the relation between competencies and EPAs? Number 1, competencies are building blocks of EPAs. Means that we need number of competencies for one EPA. Number 2, transfer of responsibility to the learner is entrustment. So that is the definition of entrustment. Then when we transfer the responsibility to a learner, and we know that the learner can perform that task without supervision. So a single EPA typically integrates multiple competencies and reflects professional responsibilities in daily practice. Means one EPA would have multiple competencies, and EPA reflects professional responsibility. So like we said, that EPA of the history taking. So EPA actually reflects the responsibility. Okay, now again, just think about it. Can you list 5 professional responsibilities of a healthcare provider? Now, I'm sure this would be different for different people depending upon the context you are working in. But can you just list, and maybe you can share some of these in the chat box, what you think is the most important professional responsibilities of a healthcare provider. If we can make that list, that would mean that is the guide for us, that how we are going to train our graduates, our healthcare provider, so that they can handle those professional responsibilities. And this is the most important and the first step in developing a competency-based medical education. Right. Hope you have jotted down some. We can discuss towards the end that what is your list and how we can achieve that. Right. The key difference between competency and EPA is that competency describes what a person is able to do. That is learning outcome, or that is an attribute, while EPAs describe what the person actually does, performs, and can be trusted to do unsupervised. Let's say here, Malik can fly airplane. So that is a competency. Okay, I say I can fly an airplane. That is my competency. But question is, would you like to fly with me? If you say yes, then that becomes EPA, that is Entrustable Professional Activities, because I have you have trust that I'm a safe pilot. So again, like the initial example of whether you trust your graduate to treat you or your loved one, or similarly this. So that shows the difference between competency and entrustable professional activity. Now, coming to the point that one EPA has multiple competencies. This is the example of EPA, which is that, let's say, EPA when we were talking about the levels, maybe level 3 or 4, and it is the lumbar puncture. So entrustable professional activity of lumbar puncture. To achieve this EPA, student must have number of competencies, and sometimes we label it as sub-EPAs, and these competencies would be based on the knowledge, skill, and attitude. So to perform lumbar puncture, student must have knowledge of circulation of CSF, surface anatomy of vertebral column, indications and contraindications of lumbar puncture, interpreting the results of CSF. So some of these are the knowledge components. Similarly, they should have a skill to perform the procedure. For example, sterilization of hands and equipment, position of patient, identification of the site, inserting the needle, collecting the sample of CSF, and filling the request form for the lab. Then is the attitude is to take informed consent from the patient. So here you see, to achieve one EPA, which is lumbar puncture, there needs to be a number of competencies. So that's what is meant by that a single EPA would require a number of competencies. So to understand it clearly, if we remember this flow: competencies, EPAs, and roles. For a professional role to play, we need a number of EPAs, and for EPAs, we need a number of competencies. Let's say role of medical expert means that we need to have number of EPAs. Remember the definition of unit of professional work. So means that we need to have number of EPAs. We need to have win the trust of our assessors that we are able to perform these competencies, so which would play a role in which will help in executing our roles. So competencies, EPAs, and roles. I'm emphasizing on this because later on I'm going to tell you that there may be some different statements in the literature, and sometimes we are confused about it. So merely acquisition of competencies does not ensure that the graduate will be able to perform the task independently. Like counseling parents about their Down syndrome child. So that is the EPA, whether a student may have some competencies, but whether they are able to perform that. Actually, competencies are scattered all over the place, and they need to be assembled to perform a task. Multiple competencies are needed for each EPAs. For example, application of knowledge, skills, and attitude for managing a case of myocardial infarction. So multiple EPAs are needed to fulfill the different roles of a physician. So there is some confusion in the terminology in the literature, and that's why I said that if we keep this in mind, competencies, EPAs, and roles, it would help to really understand it. And an individual needs to be sufficiently competent to perform an EPA. In some articles, they have different terminology, and they use the term sub-EPAs, EPAs, and competencies. So the word competency is used for the role rather than for the initial responsibility. And here is the definition and the details of sub-EPAs. And if we look at it, it comes to the same what we were saying, the competencies, the EPAs, and the roles. Sub-EPA, by definition, these are smaller tasks that make up a large entrustable professional activities. So these are actually the competencies what we were talking about, that they get when we bring them together, so they would form an EPA. So rather than smaller competencies, these some of these articles call them sub-EPAs. And the role of these sub-EPAs is to provide more detailed and accessible breakdown of professional activity. And that's because once there is an EPA, and EPA has multiple competencies, so it identify these competencies when we want to assess. When we were talking about, for example, lumbar puncture, we have knowledge, we have skill and attitude, and those are the, by this definition, they can be the sub-EPAs, and that list helps us to assess the student on those smaller components, so that we can be sure that the graduate has achieved the required skills and attitude. And the example here is that for the EPA of medical consultation, sub-EPA could include competencies like taking patient history or conducting a physical examination. So basically this explanation is to just to be careful that when we read this some articles on this EPAs and competencies, so there may be some different terminology, but actually it is, we are dealing with competencies leading to EPAs, leading to roles of a physician and surgeon. Now here we have seen these the CanMed roles of which they have identified this. The medical expert, communicating collaborator, scholar, leader, and health advocate and professionals. And then there are, for each role, there are number of EPAs. For example, EPA 1 is performing a venipuncture, EPA 2 is performing an appendectomy, and so on. So if for each of these roles, there are these EPAs, so and that's what I was saying, that the competencies dealing to EPAs and EPAs leading to the roles. This division is important. So when we want to actually prepare a curriculum, because we would always start with the top requirement and then would identify the rest of the things, which is the top-down approach, which I will explain in a short while. Right, so that was our second component of EPA. Any concept of EPA. Any questions or any comments before we move on to the next component of our presentation? Any questions related to EPAs?
There is another concept. I'm Dr. Noshaba from Namj University. There is another concept of milestone
Right.
with the EPA.
Right.
So I think we should also discuss the concept of milestone here.
Yeah, actually, if we look at it, sub-EPA, milestone, and the competencies, they are more or less the same thing. So milestone is again a stage of achieving a competency. When we were talking about the levels of, let's say, EPA, level 1, level 2, level 3, and those would become the milestones. So these are the three terms I think are used interchangeably, but thank you very much for reminding that, because that's an important point, because some papers may mention that. Thank you. Okay, Dr. Tara M.A., please unmute yourself. Yes, please.
Thank you, sir. Thank you. If you just allow me for a quick question.
Sure.
I'm really concerned that discussing EPAs might overshadow the ethics and professionalism teaching that you have kindly shared with us before. So do you think we should ensure that explicit ethics and professionalism teaching is not lost or assumed within EPA-focused assessment?
Right. Now, yeah, we shouldn't forget that ethics is, of course, professionalism, ethics is really very, very important component of our profession and our training. And obviously, the components of professionalism would also be the EPA, right? So they would start with the competencies, and of course, we do not afford to ignore this important aspect. That's why we say the knowledge, skills, and attitude should include the different components of professionalism. Thank you very much for reminding that as well. Yes, any other question or any other comments? Dr. Noshaba, was your question answered about the milestones?
Thank you, sir. But again, like we have got some overlapping between the concept of outcome and the competencies. Similarly, I think the hierarchy of milestone and EPA varies in different articles. and different frameworks have been identified for EPA and the milestone.
Yeah.
At some places, the EPA is a bigger thing, and milestone is within the EPA, and sometimes the milestone is bigger, and the EPA comes in that.
Yeah,
So there is always a overlapping concept in between.
in fact, I was myself confused for a long time.
Yes.
The competency the final, or is the EPA is the final, or is the milestone is the final? So different people have been describing it differently.
Exactly.
But after reading and considering for a long time, then I was able to actually understand that although people are using the different terminology, but the purpose is same. And just to help myself and to understand these things clearly, I devised this flow chart of competencies, EPAs, and the roles. And then whenever I read, I put those things under these headings, and it helps me to understand. You are right, there is a lot of different terms being used in different meaning in the literature. But if we group them under these, let's say, competencies, EPAs, and roles, probably that would help to understand.
Thank you, sir. Thank you so much.
Any other comments or any other questions?
Sir, Assalamu alaikum. Can I just would like to contribute to whatever you are already saying?
Right.
The
Dr.
confusion and
Aisha.
everything.
Yes, please. You're welcome.
As much as we study that, we understand that there would always be room for confusion, and I think that is necessary because that's the space where we create.
Yeah.
The confusion is
In
also
fact,
necessary.
in one of the session, I think it was Professor Gohar Wajid, he said that your lecture is very good because you have created some confusion.
Yes, sir.
So,
With regard to competencies in all these frameworks, they
right.
become important when we are designing curricula.
That's right.
And this distinction is important. How are you going to approach towards designing a program and stuff like that?
Right.
So with regard to that, which one comes in the hierarchy of designing earlier and later, that depends on the way the educator thinks about that particular task, and it's up to them how to approach that.
Right.
But for as regards EPAs and CBME, I would like to say that when EPAs were being developed in Europe, in North America, they were working on milestones. So
Right.
the same concept had just different names with regard to that.
Right.
And when you said that EPAs are the building blocks of, competencies are the building blocks of EPAs,
Right.
I think that EPAs are the building blocks of competencies because there are multiple EPAs, but the competencies are typically
You
6,
see,
7, 8,
sorry,
9.
Dr. Aisha, to cut you there. Actually, I used to think like that, but then to have an EPA, you must have a competency first. How are you going to trust somebody? EPA is entrustment, right?
Yes.
So what are you going to trust on? So there has to be a competency which you can trust.
Exactly. So this is what I'm trying to say, that the competency would come first and the EPAs would follow, because the EPAs would be the specifications that we need to have in order to be declared as competent.
Yeah, I think we agree on that. As I said, that we start with competencies, and then multiple competencies would make one EPA, and multiple EPAs would make one, let's say, a medical practitioner or role. So how can you trust unless you have a competency? So you must have a competency first, and only then you can trust on that. But I used to have similar confusions as you are sharing, and it took me a while to get these things clear in my head.
Can I, Professor Alam Sheikh, can I have a small comment? I'm sorry, I don't know how to raise a hand here.
Yeah, sure. I was just referring to one of the previous comments.
Yeah, that's why I wanted to take your permission. If you want me to add more confusion or make the things simple,
No,
first
please,
we have to.
please don't add confusion. Make it
Okay.
clear.
If you say that don't add confusion, make the things simple. Uh, as concepts, these are wonderful things. But I bet you the 54 participants here,
Right.
none of them is in a position to even develop and implement an EPA-based curriculum in
Right.
our particular setups
Right.
at undergraduate level.
Right.
And even I would say it is not advisable.
Right.
This is my take and conclusion. Second conclusion,
Yeah.
even if we successfully transition from our traditional time-based, content-based, subject-based curricula to competency-based curricula, this would be a big success.
Right.
Number three, even Oliton Kate, if you ask him, they have not been able to give you a tangible, workable plan on
Right.
how EPA-based education, and I'm talking of undergraduate level, not postgraduate level,
Right. Right.
is going to work in our environment. The last comment, there is this confusion is there in academic circles. We should always look two things. Because the things overlap, we should not develop our discreteness in the minds that I need a very clear distinction between competency-based curricula and outcome-based curricula.
Right. Absolutely
You read the
right.
literature, they say CanMed's competency-based oblique outcomes.
Right.
So the concepts, they overlap.
That's right. That's right.
And then the power struggles between different schools and thoughts and groups of medical education, like all groups, they've put them into the position to develop their own terminologies.
Right.
So they come up, okay, he's using competency, I'm going to say it milestone, etc.
Right. Okay.
The
So,
very last thing, Dr. Zafar and Iraqi have written a wonderful 3-page article.
right.
That is common myths about entrustable professional activities.
Right.
I will write the name in the chat. It's just 2 pages.
Right.
It clearly defines what are the differences between EPA's competencies and educational objectives. Will read you like 10 minutes to read, and you cannot miss
All
using
right.
these
Right.
concepts.
Yeah. That
Sorry
would
for
be
taking
helpful.
long time.
That would be helpful. But sir, towards the end of this presentation, I have made a little effort to see how it can be implemented within our setup, and I would really need your opinion once I have presented that, whether that can help or at least propose some solution how to go about it. But before that, I think I want to talk about the assessment in competency-based medical education, because it is different. The assessment, the recommended method of assessment in competency-based medical education is different, and it is stated that unless we have that recommended method of assessment, we cannot implement complement-based medical education successfully. Right. Now, there is this group of the International Competency-Based Medical Education Collaborators. So this is a group who are the leading international experts engaged in conceptual issues and current debate in field of CBME. And they have identified some core components framework for this competency-based medical education. And these are those 5 core components of competency-based medical education framework. Number 1, competencies framework means identification of competencies. Second, progressive sequencing of these competencies. Means when we are teaching this in our timetable, there has to be a sequence, a progressive sequence that we must maintain. There are certain things, for example, we are talking about a procedure, we need to teach sterilization first before performing lumbar puncture. So there has to be a sequence. Third, learning experiences that are tailored to the competencies. Of course, the competencies would dictate us what we are going to teach and how we are going to teach. And then they say that the assessment must follow the programmatic assessment. And this is what I'm going to talk about in next few slides, that the programmatic assessment is an essential component of competency-based medical education, and we need to understand what is programmatic assessment. So based on the core components of this group, the programmatic assessment should be embedded in the design and implementation of a competency-based medical program. And so what is programmatic assessment? As opposed to traditional assessment, as opposed to traditional assessment, progressive assessment takes a longitudinal and holistic approach. Means it's a, sorry, can you make yourself mute, please? Right. As opposed to traditional assessment, progressive assessment takes a longitudinal, means it emphasizes on continuous assessment. It's a workplace-based assessment. So it emphasizes more on ongoing assessment rather than summative assessment, and holistic approach to assessment, and emphasizes the learning function of assessment, means using assessment to give feedback to the student so that they can identify the areas where they need to work harder by using an array of assessment methods. So it's not only just one method, it recommends using multiple methods of assessment, because each assessment method would have its own strengths and weaknesses. So when we use multiple methods, they would actually complement each other. And purpose is to provide feedback that is assessment for learning and make plausible assessment decisions. Means that the continuous assessment would help in two major areas. One, to give feedback to the students so that they can improve. And second, the same continuous assessment would contribute significantly in making the final decision about the progression of the student. The programmatic assessment is systematic, and it is systematic since it encompasses planning. We have to plan way ahead with deliberate choices of assessment methods, scheduling, and feedback strategies. So this is something which, when we are building or developing a curriculum, at the same time, we should be talking about this assessment, and it should be planned. We should know what methods of assessment we are using. We are going to use a particular competency, where to schedule, and what would be the way and the slot and time to give feedback to the student. Programmatic assessment information on student competency and progression is purposely and continually collated and analyzed. And here is an example that what we use is the student tracking system, that the student performance is continuously monitored. This is an example of, let's say, in year 1 and year 2. And you see there are modules at the base, the cardiovascular system, respiratory system, and others. And then that is the student performance. This is in each module. This is the class average. And so we see the student performance in relation to, excuse me, can you mute yourself, please. Yeah. So this continuous this continuous assessment and the keeping a record of that helps in the way we said in the programmatic assessment, a continuous assessment. And based on this, we can actually give a good feedback to the student. For example, here in the cardiovascular system, student performance is not so good. And there would be a complete in the background, complete information that which part in this module the student did not perform well. So he or she would be counseled out that. Similarly here in CNS module. On the other hand, there may be a student whose performance is good. So maybe this is the student whom we want to prepare for example, for distinction. So means that this continuous assessment and monitoring of the student is not only to help the student to, for example, pass the examination, but also to excel in the examination. So this is one component of continuous assessment and student tracking to implement this. There are 12 principles that underpin the programmatic assessment approach, and which stand to reiterate that every individual assessment method has limitations. This is what I was mentioning previously, that there is no single assessment method which is perfect. Every assessment method has some limitations, and we need to use multiple assessment methods so that weakness of one method is covered by the other method. So these are some of the principles underpinning programmatic assessment, and I have highlighted some of them. Every assessment method is a data point. I will explain in the next slide. Pass-fail decisions are not given on a single data point, so that we cannot, on just one assessment method, we cannot make a decision of pass or fail. There's a mix of methods of assessment. This would be explained in the next few slides. Now here, if you look at the point 8, which is very, very important component of programmatic assessment. In fact, is the feature of programmatic assessment. The assessment information is triangulated from all data points towards a competency framework, and this is the assessment, the information from each assessment method is divided into the domains, and I will give an example on that to clarify that. The high stake decisions are made by a competence committee. It's not the one individual makes a decision. It is the committee who makes this decision about the entrustment. This means that only one person cannot declare that the student has can be trusted on that. There would be multiple people contributing from different areas, and their recommendations would come to this competency committee, and which would certify that the student has can be trusted on this competency. Right. Now here the word I used, the data point. The concept of data point applied in the programmatic assessment refers to information on student performance that is collected from a single assessment method. This means for example, in OSCE, we have information about the student on different domains. In OSCE, we may be mainly assessing the psychomotor skills, but at the same time, we might be assessing the attitude, we might be assessing the communication skills at the same time. So this means that one data point or one examination can give information under different domains. And that can be applied to almost every assessment method, whether it's a OSCE or whether it's a multiple choice questions or whether it is the essay type of question, long case or short case. So point here is that each assessment method or data point gives information on the student performance under different domains. So that is first concept in triangulation of information. Second, single data points are used in formative assessment. So means that we cannot make high-stake decisions on just one examination method. We can use those methods as for formative assessment or for giving feedback to the student. However, the multiple data points, the information collected, progressive accumulation of multiple data point becomes the base for making a high-stake decisions. This means that one assessment method can help to give a maximum is to give the formative feedback, but to make a decision, a high-stake decision, for example, of pass or fail or progression, there has to be information collected from multiple data points. Right. According to the progressive programmatic assessment approach, the pass or fail decision should not be reached by individuals, but rather by a competence committees. So information is passed over to the competence committee from different sources, from different data points, and only this committee is authorized to make pass or fail decision. The programmatic assessment is instrumental. That's very, very important. If you want to implement competency-based medical education, you cannot implement it successfully unless you change your assessment method as well. We have seen this slide before, and here is the assessment focus, and then there are proposed methods of assessment. Programmatic assessment. Now, this is another very, very important component of programmatic assessment. First, we said that we get the multiple, we get the information under multiple domains from each assessment method or data point. And then second is that this assessment is meaningful by content, not by method of assessment. As I mentioned, give the example of OSCE, that OSCE can assess the psychomotor skills, but at the same time, it may assess some knowledge, some attitude, communication, etc. So if we collect these marks and then send it back to under domains, so knowledge related marks go to the knowledge domain, psychomotor skills marks go to the psychomotor domain, the professionalism marks go to the professionalism domain. This means that every different assessment method would be contributing marks to these domains, and the decision would be based on the performance under the domain, not by the assessment method. I will give a practical example of that after a while, and I think that would help in understanding this. One method of assessment can test multiple domains, as I mentioned earlier, and the multiple domains can be assessed through different methods as well. The result should be collated in the form of domains and not according to assessment methods. For example, knowledge domain will receive input from multiple sources apart from multiple choice question. For example, long case, short case, OSCE, and problem solving exercises. In programmatic assessment, information from all assessment sources can be used to inform about all the competency domains. These are the things which I have mentioned just now. And here is the real example of that. Now, let's see if we identify some domains for assessment. Here in this example, there is a domain of knowledge. There is a domain of psychomotor skills. There is a domain of analytic skills, decision-making skills. There is a domain of communication. There is a domain of professionalism or attitude. It depends what are your priorities in your institutions, and then you can identify these domains. Now, when we come to the assessment methods, from each assessment method, the marks would go under these domains. For example, in OSCE, we have, as I mentioned, given the example earlier, there would be some assessment of knowledge. So knowledge marks would go under domain. The clinical skills marks would go under psychomotor skills. Similarly, the marks about the analytic skills, communication, and professional attitude. So this means that marks from each assessment method are identified under the domains and then go they under domain. So at the end of the day, the knowledge domain would receive input from all these assessment methods. Similarly, psychomotor skills would receive input from all these assessment methods. This means that we are not deciding or making a high-stake decision based on the assessment method, but we are going to make such decision based on the domains. So once, for example, the knowledge marks from each assessment methods are compiled under knowledge domain, then we would make a decision whether this candidate has enough knowledge on that related area, or does this candidate has enough psychomotor skill, has this student achieved the desired competencies. So this is a big change. This is a big change from our traditional examination. Here, the assessment methods are contributing to the domains, and decisions are being made on the domains, not based on the assessment methods. So based on the review of the results, the remediation plans are provided. A continuous dialogue between the learner and dedicated staff focuses on the analysis of competence development. So it would give the feedback to the student, and it would help them to identify their strength and also the areas where they need to work hard. And instead of conventional assessment, such as taking high stakes MCQ examination followed by pass-fail decision, programmatic assessment addresses both the attained competence levels and the process. Means that basically the summative assessment has little role as compared to continuous assessment, because it's not only the competency level, but also the processes through which the candidate has reached at that level. So programmatic assessment is collecting and combining assessment information, assessment information from different assessment methods based on the content, and then valuing the resultant information to come to a decision and making action upon these decisions. So the decisions are made based on the domains, and then the actions are taken on that. For this purpose, we need to answer following questions. Number one, what information need to be collected? Number two, how to collect the information? Number three, how to combine the information from various exam methods? Number four, how to value the resultant information and how to make decisions, and how to implement the decisions. So we need to have answers to these questions so that we can implement this program successfully. Right. Now here again, a little quiz, just to make sure that we understand what it means. In programmatic assessment, data on student performance is collected throughout the academic year. So what do you think about it? Data on students' performance is collected throughout the academic year. You can post your answer in the chat box. B, each assessment method contributes to multiple domains of the curriculum. C, for students, pass-fail decisions are made by the heads of the departments. And number 4, emphasis is on summative assessment. So actually, the last two statements are not correct. For students, pass-fail decisions are not made by the head of the department, but by a assessment committee, where all the information would go to the assessment committee, and they may not really know the student well, but what information is provided to them, they would make a rational decision on that. And the D is also not correct. The emphasis is not on summative assessment. The emphasis is on continuous assessment. So in a way, major contribution is an ongoing assessment rather than at the end of the year. Right. Okay, any comments, any questions before we go to this final segment, which I think Prof. Gohar mentioned about the limitations of implementation of CBME, but we would address and see how we can overcome those limitations in this section. But any question before that?
Yes, sir. I'm Professor Hamid Mahmood Bhatt from Lahore.
Yes, sir.
Excellent presentation and a lot of clarity rather than confusion.
Then, sir, it's not a successful lecture.
No, so far. Maybe as we proceed, the confusion rears its head, as it does always.
Right.
I would like to share an experience on behalf of the College of Physicians Surgeons Pakistan.
Yes, sir.
Where we developed a work-based assessment program, and it is hosted online. And I'm very happy that you have actually witnessed one of our presentations in Peshawar Ophthalmological Society of Pakistan meetings.
Right, sir.
And I prize your comment there that we are actually working with EPAs. And we have actually implemented them. And regarding the query by one of the and observation by one of the participants, actually competencies is the framework on which you build the curriculum document. That is what precisely has been done. And the EPAs and the work-based assessment is actually within the domain of assessment, which is a part of curriculum.
I think very well said, sir. Very well said.
That provides us a lot of clarity. And as we all educators know that assessment drives learning. So when we are actually operating a work-based assessment program, in the context and perspective of programmatic assessment that you have precisely just mentioned, so if we design our assessment for learning with WBA tools, which are EPA tasks actually, and then we build them in like 13, 14, 15, 16. मैं पंजाबी को भी आपको पता है educators पंजाबी भी use कर any language for an educator to convey the message. तो मुझे professor of orthopedics हैं, उन्होंने कहा जी आप मुझे ये बताएं कि कौन सी ऐसी 10-12 मोटी बातें मेरे orthopedic FCPS को आनी चाहिए. So I think it is a beautifully stated framework.
I think this Punjabi cannot be translated.
I can translate. I will translate it on your behalf. One of the orthopedic surgeons, actually, when I was discussing the WBA program, he said that what are the important 10, 11, 12 important tasks that a successful fellow of orthopedics should be able to do. I think that is very well placed as the framework of EPAs, because EPAs are designed by a committee of experts. That is where the faculty came in. And then you're also, the observation is very, very pertinent. The EPAs actually relate to the competencies. As you said, they are the assembled competencies.
That's right.
And then they work within broad clinical domains.
Right.
Like in ophthalmology, we have selected clinical domain and we have selected 4 EPAs for that.
Right.
We have selected procedural domain and we have selected 12 DOPS stations for that.
Right.
And for surgical skills, we have selected 2 Oscar scales for cataract surgery. So overall, we have designed, we have enumerated about 18 EPAs.
Right.
So I think the concept that and when we were designing it with Carl Golnick, who's from the University of Cincinnati, he was very emphatic that we have to keep it in a very simple, doable format.
That's right.
The discussion about competence and then milestones also came up because this is a concept with the ACGME, the milestones.
Right.
And you very rightly said that when you are achieving the level of entrustment, that is what decides the milestone achievement.
Right.
So I think overall for me, it has been a great opportunity to revisit the concepts. Thank you very much.
I think, sir, one thing which you actually said, and I think that is definitely helpful for us to understand that the competencies are the basis of developing a curriculum.
Absolutely.
And EPAs comes in the terms of assessment.
Absolutely.
So I think that statement helps clearly helps to understand what are competencies and what are EPAs. And then obviously, once we have these EPAs, as you said, for your ophthalmology, you have identified these EPAs, means that you feel quite comfortable that if a graduate can meet that. Thank you very much, that contribution, actually.
Thank you. But I'll just take the liberty. Once we were designing the program, Professor Carl Golnick was on email with us. He said, first send me the curriculum document.
Right.
And then we will discuss what work-based assessment is. So that also brings us to the same point again, that how important it is to have competency-based curriculum, which is listing of competencies.
Right.
And the assessment is actually related to the EPAs. So that makes working within the postgraduate domain practically much more simpler. Thank you.
Okay. Thank you very much. I think, sir, that was excellent comment and very helpful. Any other participant want to comment before we go to the last short component? And but it is important, especially based on the comments which Professor Gohar had just a short while ago. Yes, Professor Muhammad.
Yes.
Thank you very much. May I ask you about the competencies of this decision committee that they decide and the challenges they usually face? Thank you very much.
Yeah, so the assessment committee, what Professor Muhammad is mentioning, the composition of the assessment committee. So obviously there would be subject experts in that, and as well as from the medical education. So, and they would look at the report or feedback given by different lecturers or different components, and also the results the marks coming from different assessment methods based on the different domains. So it's not necessary that they should know the students well. They may not be the part of the examination or assessment, but based on the information provided and comparing the information with the criteria labeled, they would make those decisions. I hope that answers.
What are the challenges? What are the challenges usually faced? And could they fail those who could pass, or made decision of pass of a student that he should fail? Your experience in that?
What I feel is that the information which comes to this committee is very discrete and very objective. So there is no subjectivity. This committee is actually going to decide based on the objective information they received from different assessment methods. So it's very likely that there would be a fair assessment, fair decisions, because it is very, very objective. The problem could be the point or data point where the information is coming from. If there is some subjectivity, and obviously there is always some subjectivity in our assessment methods, let's say clinical examination or behavior or attitude. So problem can be there that the information may not be really objective, or as I said, there would be some subjectivity always. We cannot get rid of that. So the problem could be at the source of information, but not, I don't think any problem would happen at the competence committee.
My last question is that those decision committee, they decide on pediatric, internal medicine, or on the global, on everything at the end of year, like 5th year or 4th year or something like that. So,
yeah, sir, what the committee would be looking at is the domains of knowledge, domains of skills, domains of attitude. So they would be looking at the broader areas. The knowledge as a whole, but they would get, of course, information from disciplines. So they might find that, yes, the knowledge as a whole is good, but there is certain area or certain competency is not achieved. So only they would give feedback on that part, that the candidate may need to spend some more time in that particular area. I hope.
Thank you.
I hope that answers that. Yes, Professor Muhammad Aslam, sir, please.
Yes, sir. It is a comment. It is not a question. I could foresee the themes of your next talks could be EPA-based medical education, and the next talk could be roles-based medical education.
Yeah, I mean, we are in a place where things are moving very, very fast. And we really want to achieve, as I said, the goal is the most appropriate or best treatment for our patients. And we are looking, and obviously that depends upon how we treat, how we, teach and prepare our graduates. As I said, should I feel confident that my student would be able to manage my diseases during, obviously we are at the stage where we should expect some of these things. So should we be confident that our graduates would be able to treat us well? If we can have that trust, that would be the excellent reward for our teaching. Yes, Dr. Vidya, please.
So I just want to have clarification on competency and EPAs. So
Right.
Under competency, we have what we call as SLOs. So can we say the SLOs, that is specifically objectives, and EPAs are same?
Like I gave the example that the EPA is the trust. Let's say whether you feel confident, you have trust that graduate would be able to perform that particular task without any supervision. For example, competency is history taking. So do you feel confident and can you trust your graduates that he or she would be able to take appropriate history from a patient with diabetes mellitus? So it is the basically EPA is that whether you are confident, you have enough trust. In other words, you have trained your students so well that they would be able to manage that competency which you have identified.
Yes, that means SLO with trust is EPA.
That's right. That's right. Absolutely right. Absolutely right. Right. Okay, let's go to the next part, which is implementation of CBME, and there are a lot of doubts and the perceived difficulties in this area. So one is it is a top-down approach, right? So first, I think Professor Hamid mentioned it very clearly that the competencies make the curriculum, and that's what it is. Competency, for example, is graduate will be able to perform. I purposely use this action verb of perform to demonstrate its purpose. So when we say that the graduate will be able to perform, this means that assessment would be based on the performance. If we say the graduate will be able to insert nasogastric tube, so the assessment should be that student will be able to demonstrate that they can insert the nasogastric tube, right? It cannot be that the competency is to perform and assessment is on description. It has. So once, if we want our graduate to perform then and assess them on performance, then obviously the teaching method should be hands-on activity. It cannot be taught theoretically, and the content should be identified accordingly. So this is how once we identify the competencies, then as we mentioned earlier, competencies can be knowledge, can be skill, can be attitude. So all those would make the professional work unit, and then we have to make sure that the student can win our trust on that. So the competencies make the basis of curriculum development, whereas EPAs would be part of assessment, means the assessment with confidence, with trust. So how to implement CBME? This is a statement from one article, I think, in New England Journal of Medicine. The transition to CBME requires time, of course, resources, and faculty development. It's not easy, but better educational outcomes lead to higher quality and safer healthcare in the long run. So it is difficult, it's time consuming, it requires resources, there needs to develop the faculty, but at the end of the day, the result is much better. There are two major aspects of CBME, as we have mentioned earlier. One, there's no time restriction for achievement of desired competency. So it is difficult to say that, okay, we have a 5-year course or 6-year course. And then ongoing continuous assessment or programmatic assessment with limited role of summative assessment. Just keep these two major aspects and then we see how to handle this. The two important points to make sure that competencies are achieved within a specified time. 2, students can graduate only after the minimum specified time. So in our, this is about our current curriculum. The students can graduate after the specified time. Let's say 5-year course, student may take 6 or 7 years to complete, but they cannot graduate before the stipulated time of 4 or 5 years. That is our current situation. So condition 1, to make sure that competencies are achieved within specified time, the following steps should be taken. Number 1, identify core competencies to be achieved within a year or in a phase of curriculum. And assessment must be streamlined and ongoing assessment and a little bit summative assessment. And if student fails to achieve the required competencies, additional time is given, supplementary, which is, so this is exactly what we actually are doing at this stage. But condition 2, that students can graduate only after the minimum specified time, which is 5 or 6 years, and cannot graduate before the minimum specified time. So what we need to do is we need to divide our core, our competencies into core competencies, or must competencies, or minimally required competencies, and additional competencies. A student who has achieved the core competencies before the minimum graduation time will opt for additional or elective optional EPAs. That means that we have identified the core competencies, and based on that, we have the EPAs. And if a student is able to achieve these minimum competencies before the minimum time required for graduation, then they would go for these additional or elective competencies and EPAs. So that student will graduate with the minimum specified in the after the minimum specified time, but with distinction or additional certificate. This means that because we cannot graduate a student before the minimum period required by the regulatory authorities, so we can have these additional the competencies, EPAs, which a student who has completed the minimum level can opt for that, and these would be the students who receive distinction or may receive an additional certificate. So in this way, we can still implement competency-based medical education within our restricted time curriculum. So this is one suggestion to overcome that restrictions. So implementation of CBM, of course, needs resources, needs training, as I mentioned earlier. There should be clear understanding of what constitutes CBME, how we formulate the competencies clearly, and how we have the clear assessment methods. So based on this 2025 CBME Program Evaluation Summit in Canada, culture and development, not just form design, drive the change. So there needs to be a cultural change. Learning environment profoundly shapes the success of competency-based programs. So we need to address the learning environment as well. Simulation integration. Simulation integration was highlighted as an underutilized potential for assessment, advocating for its broader use. So clinical skill lab or simulation can play a major role, because when we say the competencies and when we say EPAs and the assessment of students, especially some procedures with may not be performed on patients, need to be assessed in this environment. And Canadian programs and institutions are increasingly recognizing evaluation as a cornerstone of educational quality improvement, means the evaluation of the curriculum. As I mentioned in the beginning, before that, this is I learned the use of AI, and this is the infogram which I developed using this this AI program for Google is a Notebook LM, and I fed all of this lecture into this the AI program, and they came up with it. I think took about 2 minutes to produce this infogram, and this infogram can explain the whole of the curriculum, at least the salient features. Right, and this is, as I promised, to give you the list of medical schools who are following CBME, apart from North America and Europe. There are 2 medical schools in in Malaysia, and also a school in Uganda and Nigeria. They have been successful in implementation of the CBME program. Some of these institutions may not have a complete application, but at least major aspects. And these are the institutions which are following the EPA approach. These are, I searched on the net to find out the institution which are following that. I think with that, I thank you for your attention and your feedback and discussion. And I hope it would be of some use. What we are saying is not that you start implementing the CBME tomorrow, but this is kind of thinking process and to know what is going around and what are the things going to come in near future. And we need to learn about that and understand that that is the main purpose. Thank you very much. I would be happy to answer if you have any questions. Yes, right. Professor Gohar Wajid was mentioning in the beginning about the implementation. So maybe he would like to comment on the proposal I just mentioned to take sort of best of both worlds, using this in our restricted time curriculum.
Yeah, I'll just take 1 minute to say, because when the concepts are presented, then we also need to see how these concepts will be transformed into actions. And as you have already mentioned, when you look into the practices on how EPAs are actually being practiced, Professor Hamid has very nicely summarized, and he mentioned it more from the postgraduate perspective. The learning environment and academic domains of implementation of EPAs at postgraduate level are quite different than their implementation at the undergraduate level. And College of Physicians and Surgeons competency-based curricula, they are doing a wonderful job. But when we come to the implementation of EPA-based education at the undergraduate level, that is where one of the key factors is programmatic assessment that produces that challenging environment on how to redesign the whole curriculum. And that's not, take the example of USA, as you mentioned. There are more than 200 medical colleges in the USA. And they just very recently finished the pilot testing project that you were mentioning, that was finished in actually 2022. And based on that project, they have those 13 EPAs identified. They are now developing the toolkits and implementation plans on widespread implementation of EPAs in the American medical colleges. Take the example of, for example, Sweden. There are only seven medical colleges. SCV, 7 medical colleges are in a small area in my city in Pakistan. So implementing EPAs is developing a framework for 7 medical colleges, getting them implemented in high resource country is much easier compared to EPA's implementation in low resource setting where the bulk of medical education actually lies. So it might take some time.
Yeah, so I fully agree with you. And as I mentioned, this session is not meant that we should implement it tomorrow, but this is
True.
To know what is going on around the world and what might come in our way in few years' time. So it's sort of thinking about this. It's a stimulant or knowing what's going on. So that and getting ready if at one time we have to deal with this, so should be aware of that. That's the main purpose. Thank you very much for your comments. But if you look at it, most of the innovations in medical education actually started from post-graduation, and then they distilled down to the undergraduate. So probably that the same route this would take place. Yeah, Professor Aslam, please.
Oh, yes, please. I will endorse Professor Dr. Gaurav Wajid's comment. And for undergraduates, I will say just in one sentence, in my personal opinion, in undergraduate, it is a merger of 4 C's. That is concept, contents, competency, and then is the context.
Right.
How much do they know according to the epidemiology of the diseases of the region?
Right.
So it is a delicate balance of these 4 C's for undergraduate curriculum. Thank you.
Thank you very much, sir. Obviously, context is very important. You have to identify your competencies in your context, right?
Yeah.
And of course, the assessment methods in your context based on the facilities and resources available. Yes.
And,
Any other comment? Any other
Sir, I would
question?
just
thank you so much.
Yes. Yes, Dr. Aisha, please.
Yes. I can't find the icon of raising hand, sir, so I'm speaking without that, so I'm sorry for that. So I just wanted to share one experience with you. As you already know that about 12 years ago, we started a competency-based program in one of the countries of the Horn of Africa, a very resource-limited area, and we had to really, we had many challenges. But why we chose competency-based program? Because when we did the need analysis, and we had realized that the population needs somebody whose practice can be certified. And the focus is on the practice and not just theoretical components. So we went for that and we were able to implement it at a postgraduate level. It was an MS program in ophthalmology. So yes, at postgraduate level, it was easier because you're working with not more than 10, 12 residents at one point. At undergraduate level, it would be again a challenge, but we first need to ask ourselves, why do we want to change? And once we have the reason for that, the resources and the help would come.
All right. Thank you very much for that comment. Yes, Dr. Noshaba.
Yes, thank you so much for a very nice presentation. But I would like to add the development of a contextual competency-based curriculum is again a very big challenge. And when we're talking about, I had read it, the competency framework also identified the competency at undergraduate, postgraduate, and continuous medical education level. So if we define the competencies of the 3 levels, so it will automatically show the progression from undergrad, postgrad to continuous medical education.
Right. Yeah, I think that's a fair approach as well, because we cannot afford to have 2 separate.
Exactly. So we need
curriculum.
to identify
if
levels.
Our undergraduate curriculum is totally different than our postgraduate curriculum. Our postgraduate curriculum is, let's say, competency based, and we have EPAs, and then it would be a shock for our graduates who are entering the postgraduate program and totally different environment. So there has to be a continuity. And I think that is the main reason that all the major changes over the time took place was initially in the postgraduate, and then obviously came to undergraduate, because undergraduate must be trained for their postgraduate requirements. So it
and
is
that comes into the framework. Then that makes a proper framework for a continuum of medical education.
That's right. So we cannot have 2 totally different approaches in undergraduate and postgraduate. So if we agree to have in the postgraduate, then we cannot run away from implementing it in undergraduate.
I think if I can chip in, sir.
Right.
I think it is a great discussion in terms of the effort and energy that you have put in. The concept of programmatic assessment also has to be implemented in stages.
Right.
We actually struggled with the competence committees.
Right.
That all the longitudinal WBA tools and EPAs are then integrated, and you take decisions based on those cumulative data points.
Right.
I think that is something which needs faculty development and capacity building. For the moment, what we have done is for each EPA or WBA tool, we have given two binary options to the supervisor. One is remedial, and one is after a month or so, 4 weeks or so. As you just rightly said, the whole idea of the EPA and the WBA tool is actually to give feedback, constructive feedback to the trainee, and then fill up the deficiencies. So after a month, the trainee is again given the opportunity to repeat, and then he is actually certified as to have attained competence in that. Now there is a little confusion. We have actually adopted the ICO scales of Dreyfus and Dreyfus because we are talking of tasks.
Right.
So they are actually they are measured on the Dreyfus and Dreyfus scale, and they are certified as to be entrustable on the competence scale, which is not the expert scale. Of course, at the end of the training, you need to produce experts.
Right.
So for two of the tools that we have used, OCEX, which is ophthalmic clinical evaluation exercise, which is just like a short case.
Right.
And for the surgical skills, we use Dreyfus and Dreyfus scale. And there, the term actually for the supervisors was a little confusing, that if you're using the concept of milestones and then you're certifying for entrustment, you're still using the term competent. But that competent is actually as you rightly said, it is the level of doing it unsupervised.
That's right. That's
So
right.
that is how I look at and resolve the Dreyfus and Dreyfus scale competence level. So I am enabled, and I will also now at the very last, since I have been at the faculty of Fatma Jinnah and Allama Iqbal, we introduced the surgical skills when the WFME undergraduate program came for inspection. We actually made the curriculum committee, and the 5 main subjects of pediatrics, surgery, medicine, gynae, were actually given 10 surgical skills stations. So that we actually tried to visit the dimension of EPAs in those surgical skills stations and simulation labs, as you rightly said. And that because for an undergraduate has to have sufficient number of tasks certified with which they can actually be a good house officer.
That's right.
Then on the continuum prepare them for postgraduate training. So it is a continuum, and it is a changing and dynamic situation. And I'm glad that you're spending so much energy with us. Thank you.
Thank you very much, sir. I think the last statement I would like to give is that many of us are okay with competency-based medical education at the postgraduate level, but we have a lot of reservation for undergraduate. But as I mentioned earlier, how can we afford to have different approaches in undergraduate and postgraduate? Either we have to align our postgraduate with our existing undergraduate training program, or otherwise, the other way is that undergraduate training has to be changed to be in line with the postgraduate education. With that, I thank all of you for your kind attention, and hopefully you would leave with something to think about, and ready to face these challenges in near future. Thank you very much, everybody. Thanks.
Thank you very much, sir.
And yes, Dr. Lal mentioned the Happy New Year. Yes, Happy New Year as well.
Happy New Year, sir. Thank you so much.
Thank you.
Thank you, sir.
Thank you. A blessed year. Thank you.
Thank you. Bye-bye.